So today we're talking about AFib and how we need to get our rhythm back. So there. We think of AFib in the traditional, in the current settings, we think AFib is new. Just because we're learning about this, we've gained more understanding of this arrhythmia very recently. However, looking back at medical texts, first mention of what I think was AFib was mentioned in, it was found in one of these Chinese books in 2598, and it was, somebody described it as when the pulse is irregular and tremulous and the beat occurs at intervals and the impulse of life fades, and the pulse is slender, small, then feeble, but still perceptible and thin like a silk thread, and the impulse of life is small. And this is, I think, is the first mention of what I think is atrial fibrillation. And this is from 2500, before Christ. So now we move on to the current times. Robert Adams, as shown in this picture here, the big picture, 1827, he was probably the first person to recognize atrial fibrillation. Can you guys hear me? No? I'm sorry.
I can.
Sorry. Oh, okay. I'm sorry. I'm sorry. I thought this was working. So Robert Adams was the first clinician to actually recognize atrial fibrillation, but he described that in the setting of mitral stenosis and associated that with valvular disease. And hold on. Okay, this is not working again. But then 1900s, Eindhoven discovered and discovered the electrocardiogram machine, and he used it to define different arrhythmias. But it wasn't until 1909 when Robert Lewis came along, and he was the first to actually get a recording of atrial fibrillation, and that's how we started learning about this arrhythmia. Then we move on to the 30s, and then further down 60s, where Bouillon looked at digitalis and digoxin, which we started using at that point, and which actually showed to control the ventricular rates. And we've used it off and on even now. And then Dr. Lown decided that, and he found out that a good treatment for atrial fibrillation was to reset the heart, which he described as cardioversion, where we shock the heart back into normal rhythm. And that started a whole era of what we now know as atrial fibrillation and increased our understanding. So now we know that AFib is a sustained arrhythmia. It affects about 1% of the general population. And it's pretty common, and especially in the elderly and people who, over the age of 75, its incidence is about 10%. Worldwide, about 30 million people are affected. And the lifetime risk of AFib after the age of 40 is about 26% in men and about 23% in women. And AFib is also associated with decreased quality of life, increased mortality, and has a 30% higher risk of death. And I'll go over these a little bit later. AFib in itself confers a 5-fold risk of stroke and also twofold risk of dementia. And also people who remain in AFib have a high risk of developing congestive heart failure. And there are some reports that show that AFib also confers a higher risk with myocardial infarction as well. Again, it's an important clinical entity that we need to understand better and treat. So as I mentioned before, patients who have AFib have higher morbidity and mortality. So people on average who have AFib spend about $9,000, accrue about $9,000 more per year in medical costs. And the annual U.S. healthcare costs associated with AFib has been growing and actually are estimated to grow to $6.65 billion, and they are supposed to actually projected to triple by year 2050. So as our population grows, we are seeing more and more of atrial fibrillation. And we do have treatments, we do have treatment strategies, and I'll describe those later on, but they're not the most optimal. So we need to continue to gain better understanding of this arrhythmia so we can treat it a little bit better. And believe it or not, even though we may think that we know the mechanisms behind atrial fibrillation, it's a pretty complicated arrhythmia. Actually, as a side note, before coming to VCU, I was doing residency up in Boston, and I did research at genetic research on AFib, and it turns out AFib is, even though we do see it in elderly population, AFib is also found in people and kids, in young kids as young as 19, 20 years old. And in those cases, AFib has a genetic predisposition, and it runs in families, and we did a bunch of molecular and genetic research on those patients. And that's actually pretty interesting as well, but I won't go into that today. So, yes, ma'am.
The one before that, right, the next one. That last one, that last
Myocardial infarction. It's heart attack. People, yeah, it's heart attack. You know, when we think of heart attack, we think it's more of a plumbing issue where the blood vessels get blocked, and the heart doesn't get enough oxygen, and it leads to that causes heart attack. We think AFib is an electrical issue, so it shouldn't be associated with that, but studies show that there is an association between the two. You're welcome. So, talked about that, and this is a map of the U.S., and this is in between 2007 and 2012. And these are all the hospitalizations that occurred during that time that were attributed to atrial fibrillation. So we can see that this looks pretty remarkable, that atrial fibrillation is a chronically growing issue and leads to hospitalizations throughout. And so that's, again, tells us that we need to do something better, and we need to have a better understanding of this arrhythmia so we can treat it better. But what is atrial fibrillation? Let's get to the gist of this. When we look at how the heart works, so our normal pacemaker sits in the top chamber on the atria of the heart on the right side, and which is known as a sinoatrial node, and that controls how our heart beats. So the sinoatrial node sends an impulse, an electrical impulse, and that impulse actually travels down, gets spread out through the rest of the heart. But the main conduction fibers lie within the middle of the heart, and so the impulse travels to the middle and it spreads out to the different chambers of the heart. What happens in atrial fibrillation is there's an electrical storm within the heart, as shown here, and I'll play a video for you as well. There is an electrical storm in the upper chambers of the heart, so it suppresses our current pacemaker, and that leads to an irregularity in the rhythm itself. So if you look at this EKG tracing here, so we see a regular rhythm, and then when we look at a tracing in atrial fibrillation, it's pretty irregular, and it just looks bizarre. And that's what the atrial fibrillation is. And I'll play this. And we as clinicians, we identify AFib by identifying and localizing different segments of the EKG, and so this EKG shows, we call this a P wave, a QRS, and a T wave. So the P wave represents atrial activity, and that's what we should see in the normal rhythm. But when somebody has atrial fibrillation, the atrial activity is bizarre. It's just irregular, and so it disappears. And that's one of the clinical findings that we see on electrocardiograms in patients with atrial fibrillation. So I'll play this video here, and hopefully it'll do a better job of describing what atrial fibrillation is. It's playing. There we go. So this is what we expect to see in a normal heart. The impulse travels from the top to the bottom, and a heart is beating synchronously. What happens in atrial fibrillation is there is an electrical storm that causes the heart to just beat out of rhythm, and that's what gives rise to all the clinical issues that happen, which I am about to go into next. So what are the mechanisms behind atrial fibrillation? I know it's pretty complicated, as I mentioned before. People who have high blood pressure, these are people who have obesity issues. Overweight people have higher risk for developing atrial fibrillation. And believe it or not, a lot of people don't realize it, but sleep apnea, it has a huge correlation with atrial fibrillation. And so that's something that we're starting to recognize, and now whenever a patient comes to see me in clinic, that's one of the biggest questions I ask. Do you have, or ask their partners, does your family member have sleep apnea? Do they snore a lot? Do they stop breathing in the middle of the night? And if there is a reason, then I would work that up a little bit further, because there is that association. In the past, atrial fibrillation has also been known as holiday heart syndrome. And the reason is, what we found was that there was a huge uptick in atrial fibrillation during the holidays. So people were drinking a lot, right? So we like to drink during the holidays. So all these people were just binging on alcohol, and then develop atrial fibrillation, would come to the emergency room, and hence that syndrome was described. We don't call it that nowadays, but there is that historical significance to that. Some people who have congestive heart failure because of other issues, or who have had heart attacks, they can develop some scarring within the upper chambers, the atria, and that can lead to atrial fibrillation as well. And then, as I mentioned, there are some genetic, some families with genetic predisposition, and those are basically people are born with it, with atrial fibrillation, and we see those sort of conditions in young kids. And the youngest patient that I had was 19 years old, and so in those cases, we think of it as a disease of the aging population. In that case, that wasn't the case. It was not, and it actually ran in families. His parents had AFib very early on, and so forth. So, but majority of the atrial fibrillation that occurs because of somebody having high blood pressure, obesity, or sleep apnea, or heavy alcohol use. In terms of the risk factors, as I alluded to before, about less than 1% of individuals, 60 to 65, but that goes up. The risk goes up. About 8 to 10% of individuals that are over the age of 80 develop atrial fibrillation. We find it more in men than females. And it's predominant more in Caucasians than in black people. Presence and severity of underlying heart disease, meaning people who have who have had heart attacks, who have diabetes, who have congestive heart failure, they actually develop atrial fibrillation. They're at high risk for developing atrial fibrillation. Sleep disordered breathing, as I mentioned earlier, sleep apnea, and high blood pressure. Those are the things that actually eventually have a high risk for leading to atrial fibrillation. And the way sleep apnea causes or is associated with atrial fibrillation is when we breathe, when we stop breathing, we actually inhibit our gas exchange in the lungs. So we breathe in, blood goes to the lungs, picks up oxygen, and comes back to the heart. What happens when we stop breathing? Well, it changes the dynamic. So all of a sudden, that blood is not getting enough oxygen. So when that non-oxygenated blood gets back to the heart, it causes some changes, structural changes within the heart itself, and also changes the pressure gradients within the heart chambers, and that can lead to atrial fibrillation by actually causing a stretching of the top chambers. So I have a mnemonic here for the risk factors. It's called PIRATES. Pulmonary embolus, which means somebody who has had clots in their lungs, or any pulmonary disease, COPD being one of them, And so that's associated with atrial fibrillation. Ischemic heart disease, meaning people who have high risk of having heart attacks or blockaged blood vessels. There is an entity called lone atrial fib, or it's also known as idiopathic, which again we see in families, and this is found in younger patients or younger people. Especially in the hospital setting, we find that a lot when somebody has an IV line, intravenous catheter, which is sitting in the upper chamber of the heart and is just tickling the heart, and that can throw people into atrial fibrillation. As I mentioned before, the first contemporary definition of atrial fibrillation was in the setting of mitral stenosis. So mitral valve is a valve on the left side of the heart, and when people had rheumatic heart disease or rheumatic fever, they would eventually develop that mitral valve would become very clotted and would not open properly. And those patients ultimately developed atrial fibrillation. So there is, even though we don't see mitral stenosis much, there is an association with that. Anemia, somebody is bleeding or has low blood counts. Alcohol, as I mentioned earlier, holiday heart, advanced age being another one. Thyroid disease, elevated blood pressures, and sleep apnea, or somebody who is sick and has an ongoing infection are also at risk for developing atrial fibrillation. Classification of atrial fibrillation, for a specialist like myself, I don't look at atrial fibrillation, I have to classify it. I have to, because it changes the treatment and the management. So important to understand paroxysmal atrial fibrillation from persistent atrial fibrillation. Paroxysmal AFib is any AFib that is greater than 30 seconds that breaks by itself, meaning terminates, and in less than 7 days. So if somebody has atrial fibrillation for just 30 seconds, that is considered clinically important or significant atrial fibrillation. If somebody remains in atrial fibrillation for more than 7 days at a time, then it becomes persistent. And the mechanisms for those are very different in terms of what's going on inside the heart. So, and then eventually so this is also, you can think of it as a progression of disease. Atrial fibrillation starts as a paroxysmal issue where people go in and out of AFib. Then it becomes persistent. You remain in AFib for longer and longer. And then you come to long-standing atrial fibrillation where you remain in AFib for more than a year. And if that's not treated, then you go to this next stage, which is permanent atrial fibrillation, where you just remain in AFib. Your pacemaker just stops working, and you remain in that rhythm incessantly. Important to point out that paroxysmal atrial fibrillation, persistent atrial fibrillation, those are easy to treat with the current techniques that we have, the current therapies that we have. Long-standing and permanent AFib, very difficult to treat. And that becomes, people end up having surgeries, one surgery after another, and they still remain in atrial fibrillation. And at that point, the treatment actually becomes just disconnecting the top and the bottom chambers of the heart and putting a pacemaker in. So the body just doesn't care about the atrial fibrillation because you've taken over the heart with a pacemaker. And that's sort of the last case scenario or last treatment therapy or therapy for AFib in that case. I've mentioned lone AFib, and non-valvular AFib is also important because whenever we see AFib, we need to also characterize whether this is something reversible. If somebody has a valve disease, then it becomes important to fix that disease, right? Fix the underlying cause. So, but a lot of times what we see now, what I deal with nowadays is non-valvular AFib, where people have normal-looking heart, there's no valve disease, all the valves are looking fine, but they still develop AFib, and so there's no reversible cause. And that's when we go to the treatment strategies that I will go into again. But if somebody has, for example, their valve is tight, then we have to open up the valve, and hopefully that will treat the underlying or the atrial fibrillation, and that does happen. But the majority of the patients that I see in clinic usually have non-valvular AFib. So what are the symptoms? people actually complain of palpitations, which means their heart's just beating funny, and either beating really fast or really slow, but it's just beating irregular. They feel it, and people become very short of breath, and that's listed as dyspnea. People feel tired. Their heart's just not pumping right. So all of a sudden, they were able to walk 2 miles, and then they'll come and tell me, I don't know what happened. I was fine 2 weeks ago, and all of a sudden, I walk 2 blocks, and I'm just tired. I just don't want to get out of bed. And that's some people feel that. Some people feel lightheaded, and in some cases, people have passed out. People don't pass out because they're in AFib. People pass out when that happens is people are in AFib for a long time, and then suddenly AFib breaks, and they go into normal sinus rhythm, and your pacemaker takes a while to kick in, and that causes your pacemaker to sort of pause, and that's when people pass out. And as I mentioned, AFib also increases your risk for developing having heart attacks, which is usually, it presents as angina or chest pain, and people with AFib can also have chest pain even though they're not having a heart attack. So not all chest pain is heart attack. As I said, people can have all these symptoms, and in terms of what palpitation is, people would describe as drums pounding in my chest, thunder rumbling, or fish flopping in my chest. And so these are some of the symptoms that people describe. So why do we worry about AFib? It's, I've been, last 10, 15 minutes I've been talking about it, but why do we worry about it? Biggest thing that it leads to is stroke. I mean, I think on a scale of benign things to really bad things, stroke is one of those that is really high up in anybody's list. People, that's the worst thing that can happen to anybody. They become debilitated, right? And so that is the biggest risk. And as I mentioned before, 5 times higher risk of having a stroke because of atrial fibrillation. Untreated AFib can lead to congestive heart failure, meaning their heart muscle just, over time, it just tuckers out. The heart that was beating synchronously and pumping, both chambers pumping at the same time, all of a sudden it's now just flopping around, and the heart muscle doesn't like it and just gets very weak. So how do strokes happen because of atrial fibrillation? As I showed you in that video, when we're in normal sinus rhythm, impulse goes from the top to the bottom, and all the chambers squeeze synchronously. In atrial fibrillation, the top chambers are just quivering away. They're just going erratically, and the blood flow, which is supposed to go from top to the bottom, it's not happening in a laminar way, meaning now blood is just swishing around in different chambers, and because of that, blood clots, tiny blood clots, can form in a chamber of the heart known as the left atrial appendage, and this is a remnant, a vestigial remnant of the heart, and it sits in the back chamber of the heart, and tiny blood clots can form, and these blood clots can actually travel and can cause a stroke. And the stroke risk with AFib is in less than 60 years of age, people younger than 60 years. Without AFib, it's 0.5%. Greater than 80 years, over 80 years, it's about 3%. But with AFib, then even younger people have a high risk of having strokes. So again, very important to understand why we worry about this thing. So when I see a patient who has atrial fibrillation, I try to calculate their risk of having stroke. And there have been many algorithms that have been developed, but one that we use all the time is called Chad's VASC. So, and it's listed here. So I calculate somebody's risk of having a stroke based on this. So the higher you score on this chart, the higher your risk of stroke is, and the significant the need is for being on blood thinners or stroke prevention. And as shown here, age is one of those. prior history of stroke is very, so if somebody has had a stroke, they automatically are high risk. Diabetes, age greater than 75, and I'm sorry ladies, but female gender confers an extra risk, so it buys you an extra point. So that's how we confer or calculate somebody's risk of having stroke. And this doesn't mean that if somebody has a score of 1 does not mean that they're going to have a stroke right away. We calculate somebody's yearly risk, and the yearly risk ranges between 1.3%, 1.3 to 2% in somebody who has a score of 1 to 6 or 7% in somebody who has a score of 6. So, and this is a yearly risk, meaning every year it accumulates. And as you get older, your risk goes up. So what are the strategies that we use for treating atrial fibrillation? In the immediate setting, we think about controlling somebody's rate. If somebody is going 150, 160 beats per minute, they won't feel good. They will feel tired, get short-winded, there's a fish flopping in their chest. So we have to control the rate. We slow down the rate, we actually provide some symptomatic relief. So we do that in the immediate term. Preventing thromboembolism, which means preventing stroke. Thromboembolus means a clot that travels, so a traveling clot. So we need to take care of that clot. Sir?
What are you using as a range for the pulse, the rate control?
So our normal pulse should be between 60 to 100, regular pulse. And in somebody who has atrial fibrillation, their resting pulse should be between 100 to maybe 110. And with exercise should be around, or not, when I say exercise, I mean when they're walking around, should be around 120 to 130. Ideally less than 130, but we will tolerate that range. Any questions? Yes, ma'am.
My niece had leukemia.
Yes, ma'am.
Okay, and she had chemotherapy and radiation before she was 2 years old.
Mm-hmm.
It has damaged her heart. Now, would she be at risk for AFib?
It depends on what sort of chemo and radiation somebody has received. Yeah, there are radiation, particularly if there was radiation to the chest region. Radiation can cause scarring of the heart, and those people sometimes develop atrial fibrillation. There are some chemo agents that actually cause not atrial scarring, but they cause scarring inside in the ventricle, which is the bottom chamber, and they have different arrhythmias. So they develop congestive heart failure because of that. But there are some very few, not very few, but there are a few agents that cause that. In terms of atrial fibrillation, I would say more radiation than the chemo. Yeah.
Question.
Yes, sir.
What would be your recommendation about exercising for someone with a heart rates resulting from that?
It's a really good question. I was talking to somebody just a couple of days ago, and they told me that they used to be, that he was a bicyclist and would ride 50, 60 miles a week. And actually turns out people who do very high intensity workout for many years, over long periods of time, they actually have a higher risk for developing atrial fibrillation. We don't know why. So high intensity workout also puts you at a risk for developing atrial fibrillation. But people who have atrial fibrillation, as long as you're able to tolerate the exercise, there is no rate cutoff. Because our rate should go up, our heart rate should go up with exercise. But some people cannot tolerate that rate, even at a rate of 120 beats per minute. They become very tired and symptomatic. So in that case, I would say not to do much. But if you're tolerating the exercise, then continue doing it. It's not going to hurt you. So.
Would it actually be good for you if you can go as high as you can tolerate?
It's good for the overall heart health, not for the atrial fibrillation, but overall heart health, it will be good. And also your lung health, so overall general health, it will be good to exercise as long as you can tolerate it. Yeah. And so, and in the long term, what we do, so we go from rate control to rhythm control. We need to do something about the rhythm itself. And how do we do that? And actually, before I get to it, when I want to answer this important question, when is anticoagulation indicated? And the answer is when the risk of having a stroke exceeds the risk of serious bleeding because of blood thinners. This slide is slightly old because now we're using, now the current guidelines actually recommend starting people on blood thinners who have CHA2DS2-VASc of even 1. And the European guidelines are pretty strict. The US guidelines are kind of a little bit of relaxed in that sense, but we always start even though your risk is 1, you only have high blood pressure, I would still start them on a blood thinner just because we need to protect people against stroke. What are the options for people who cannot tolerate blood thinners? I've seen a lot of patients who are just very high risk of bleeding. They have had bleeding in their bowels, in their urine, or they fall a lot, right? Elderly people, we've had so many patients who just lose balance and they fall a lot. So what do we do in those cases, right? So in the clinical practice, what we do is we actually calculate somebody's risk of having a stroke and we weigh it against their risk of having bleeding. So there is this algorithm called the HAS-BLED score, and so we calculate somebody's risk of having a stroke with this, and we weigh the risks and the benefits, and that's exactly what this is risk-benefit analysis. And when patients are high risk of a stroke and also have a high risk for bleeding, then recently there has been a different method for treating those patients, which is called a Watchman. It's an invasive procedure where we put a plug, we put a seal in the left atrial appendage. Here we actually seal it off by putting a plug in there. And in these cases, people remain on blood thinners for about 30 to 45 days and then they don't need any blood thinners at all. They can be okay with just aspirin alone. And this is, I would say, kind of new. It's been on the market for maybe 5 or 6 years, and we do them as well. But only very few people qualify for that. It's not indicated for just anybody. As I said, it's an invasive procedure, so with any invasive procedure, the risk of complications goes up. So we have to weigh the risks with that as well. But that is an option. In terms of drug therapy, this is a little bit complicated and a little busy slide, but we use multiple drugs. We use drugs to control somebody's heart rate. These don't do anything for the rhythm, for the atrial fibrillation. And then we also have these rate controlling agents and antiarrhythmic agents. So these are just purely to slow somebody down, and this is to try to convert them into normal rhythm. So, and the antiarrhythmic agents in the second panel here, these can be toxic, so they have to be initiated carefully. And some of these, I bring these people in and they end up spending a couple of days in the hospital because I want to make sure that they're doing okay on these medicines and they're tolerating these medicines. So these are the medical options, medical therapies that are available.
Do sometimes the beta blockers and calcium channel blockers used in conjunction with each other?
They can be, but at the same time, if we were using 2 of those agents together, then the risk of really slow heart rhythm goes up. And so I try to avoid combining those 2. I've seen that happen, but I personally stay away from that. If I have to use 2 of these agents, then I go to the next step, which is the antiarrhythmic agents. Yes, ma'am. Yes, ma'am. No, she was talking about the beta blockers and the calcium channel blockers together. Yeah. Most of the time I use beta blockers or calcium channel blockers in addition to the antiarrhythmic agents. So those are safe. But combination of this class just increases your risk for developing very slow heart rates, and that's not good either. So, yeah.
What is a class 3? How is that different from the rest of them?
It's just the way they work on the heart muscle itself, and so class 1 agents, they actually work when somebody's heart is faster, so they are more effective when somebody's heart rate is very fast. Whereas class 3 agents, they are more effective when somebody's heart rate is slow. So it's just the way these drugs are. Yeah, it's the physiology of, or the pharmacokinetics of how these drugs work. So, and so these are some schema that I will show you about what I go through in terms of when I'm looking at selecting different drugs for my patients. And these are for rate control. So as you had mentioned before, beta blockers, calcium channel blockers, those are the first agents. And in some people who have COPD, meaning they have lung disease, I personally do not like to use beta blockers. I would rather go to calcium channel blockers because people otherwise develop really bad lung disease. And when these fail, then the next step is to use a medicine called amiodarone, which can be, it's an antiarrhythmic, but it can be used as a rate control agent as well. And there is a little bit of data supporting the use of digoxin. I think it's losing its, it was popular at one point, but it's not these days. So I don't like to use digoxin because it's very weak. And in terms of how do we control somebody's rhythm, and there are different agents, as I had mentioned before, class 1 and class 3 agents. And when things don't work out, we can always go to amiodarone, which is sort of a gunshot approach, and try to control the rhythm. And actually, the guidelines have even changed even now, where instead of going to these medicines, we can actually go directly to catheter ablation as well. And that's what it brings me to this slide. And what that is an invasive procedure, and that's what we do all the time, where we bring people to the lab, to the electrophysiology lab. And what we do is we put catheters through the groins, to the veins in the groins, and these are tiny spaghetti-like catheters that sit in different chambers of the heart. Using one catheter, and we actually we make a tiny 1 or 2 punctures, or make tiny holes actually, in the wall that separates the 2 top chambers to go onto the left side. Okay, and I guess I should have mentioned the mechanism for the atrial fibrillation. So AFib actually originates, the main triggers for AFib are the veins. So there are a couple of veins, or 4 veins, that come from the lungs and bring blood back from the lungs into the heart. So these are the veins that are shown here. And AFib triggers actually reside in the junction where the veins come and meet the heart. And what we do is we go into the heart, we put catheters inside the heart, and we electrically isolate the veins by burning at the mouth of these veins.
What are the diagnostic catheters actually diagnosing at those points it shows them?
Electricity, the electrical signal at different points of the heart. So this is picking up electrical signal in the bottom chamber. This is picking up electrical activity near the pacemaker of the heart. And there are different structures that we keep an eye on, electrical structures. And so that's what they allow us to, they are sort of guide maps as to where we need to go.
So right now, at this point in time, you actually have to have a catheter to pick up that electrical
Yes, ma'am.
activity?
Yes, ma'am.
It's not, it has to be invasive.
It has to be, well, an electrocardiogram, the tracings that I showed you before like this, so those are from the outside. But when we do the ablation or any study, we want to look at what's actually happening inside the heart. And that's what these catheters allow us to do. They allow us to pick up that electrical signal.
So it's at certain points in the heart that it's picking up the
Yes, ma'am. Yes, ma'am. So there are 2 ways of doing an ablation procedure. And I apologize, I wanted to show you the videos, but one is by electrocautery. So we go inside the heart, with this catheter. It's an ablation catheter, and we burn a circular ring around the mouth of these veins and electrically isolate the veins. What that means is whatever electricity or electrical activity is happening inside the vein does not make its way out into the heart, okay? Because that's how AFib happens, is those veins start firing and capture the rest of the heart, and that's what causes them to sort of start quivering away. That's one way we do that, by burning, by electrocautery. There's another method, and again, video, my computer is failing me today. It's called a cryoballoon ablation, where we actually put a catheter, and this catheter has a balloon at the tip of it. So we put the catheter inside in the vein, blow up the balloon, and occlude the mouth of the vein. So, and then we fill that balloon up with really cold liquid nitric oxide. And so what it does is just sort of freeze burning the tissue at the mouth of the vein, and that's how we electrically isolate those.
So for choosing ablation over medication is, at what point do you?
Symptoms? In the past, as of a couple of years ago, the guidelines recommended using medicine, using antiarrhythmic medicine, and if somebody failed antiarrhythmic medicine, then they would say go to the next step, which is ablation. But catheter ablation has actually become not an alternative, but it has become sort of the treatment of choice, because the success rate from a catheter ablation is about 70–80% in terms of treating atrial fibrillation. It doesn't cure anything. It does not cure atrial fibrillation. I want everybody to understand that. It's not a curative procedure, because when we do catheter ablation, we're burning or we're taking care of one of the major mechanisms of atrial fibrillation, but different mechanisms may be present. And so that's why we always keep people on blood thinners even after the ablation, just to protect them from having stroke in the future. Yes, ma'am?
Which is better of the two? What is it?
I'll-
Risks of the two?
So I was going to go over that next. Yeah, it's coming up.
Do they stay, after an ablation, do you stay on blood thinner the rest of your life?
It depends on patients. It depends from one patient to the other. I recently did a procedure on somebody who was young, had no other risk factors, and procedure went great. I mean, he was about 55, 56 years old. Brought him back and has no AFib. So at that point, the risk of having a stroke is low, right? So in that case, I will have that discussion with them, and it's an ongoing discussion between me and the patients. But somebody who is high risk, I'll be very careful about taking them off of blood thinners. But somebody who is low risk, yes, yeah. Yes, ma'am?
You do ablation for somebody that's in chronic AFib?
It has been done in the past, but the success is very low. We get very little bang for our buck. And again, so in those cases, people end up going through multiple procedures, and it doesn't really do them any good. And they end up actually getting, you go through more procedures, one after another, and the risk of complications goes up. So in those cases, I do not recommend that. Heather?
You can go ahead and finish.
No, go ahead.
So I was going to ask, do you see recurrence in one particular one over the other for the cryoablation versus the RFA?
It's coming up, yeah.
And then I actually have one other one. With breakthrough AFib following ablation, what's the mechanism regarding if you have a successful ablation, why is there still breakthrough that lasts?
That's a really good question. I'll go back to, let me do that. So when we're burning, we're using very high resolution mapping to pick up local electrical signals. And that's what we're doing. We're just doing one point by point. We can miss some triggers in doing that. And sometimes we also, when we're burning, we actually check to make sure that, we're drawing a scar line, right? So that's what I'm doing, is drawing a scar line. And so I check after I treat each vein, I check the vein to make sure that the electricity doesn't make its way out. While I'm burning, there can be a little inflammation, some swelling within the heart itself, and that causes that electricity from from coming out. So I can get a sort of a false sense as well. Over time, even though the ablation procedure goes very well, sometimes connections form after months to years as well. So tiny gaps can start forming, and those can lead to recurrence of AFib even years after. And sometimes we see that. And as I said, 70–80% success rate with AFib ablation, and that's with first ablation attempt, meaning 20–30% of the time people need a second ablation procedure, a touch-up to make sure that we've taken care of all the triggers. Yes, ma'am.
So one procedure, you're blocking the vein, cutting it off totally. The other, you're just running around it. So when you block it, it doesn't set up collateral circulation?
No, we're just doing it for 20 to 30 seconds at a time. Yeah.
So you don't leave that balloon?
We don't leave that balloon in there. Nothing is left in the heart, yes. Yeah. So we just we occlude the vein for about, for the max,
Change the activity.
just to provide a freeze burn in that area. And that happens over about 60 seconds. And then we take the balloon off, yeah. And we do that for each vein. Yes, ma'am.
And you determine whether to do the freezing versus the burning based on whatever their criteria is.
Exactly. So I had shown you the different classifications earlier. Paroxysmal, AFib, cryo. I personally choose cryo for paroxysmal AFib. People who have persistent atrial fibrillation, then I do the radiofrequency, which is an electrocautery. And just because they may have other triggers, with somebody is in AFib for so long, you develop different triggers, and then with the high resolution point-by-point mapping, I can actually find those triggers much easier than the freezing balloon. Yes, ma'am. So somebody had asked me about cryoballoon versus radiofrequency, as you mentioned. So there was a trial, it was called Fire and Ice, and they actually compared the two freezing versus burning, and it was a multi-center trial, and it was a big thing, and it's actually, can't believe it's become old now, but it found that in terms of efficacy, primary efficacy point was freedom from AFib, and radiofrequency and cryoballoon, no difference. So you can do either or, and it'd be good, and you can't go wrong with either one of those. And again, the big thing that came out of this trial was that centers that did more than 50 AFib ablations per year, so if a practitioner has been doing AFib ablations and consistently, and so the chances of complications are less, and the success is actually better. Just makes sense, right? Somebody's been practicing and is more apt at doing those, will have better numbers and better in terms of complications, so they won't have that many complications and would have better results from the atrial fibrillation. So in summary, we talked about atrial fibrillation. I hope I was able to convey to everybody what AFib is, what the mechanisms are, what the symptoms are, and that's very important. Understanding the symptoms is important because that's how we modify somebody's risk for having a stroke. Actually, I had a gentleman today was referred to me as AFib, but he presented to me he was not in AFib, and so the question is, do I start somebody on anticoagulation or blood thinners because somebody said that they were in AFib? No, but I have to find out whether that person is in AFib. So it's important because blood thinners are blood thinners, they make you bleed. So we have to make that decision very judiciously. So we do need to mitigate somebody's risk of a stroke, either with medicine or with a left atrial appendage closure with the Watchman device, as I had shown earlier. There are different treatment options that are available, rate control, rhythm control, and then when medications fail, we can go direct to ablation, or when somebody says they'd rather not be on medicines for life, then ablation is a viable option, and it is low risk and has I would say, I personally consider better success rates, and things are getting better. Technology is getting better as we're understanding this arrhythmia even more. So this is our team at VCS. Dr. Gilligan, Dr. Joyner, and Dr. Shah and Mohanty, they're over at Chippenham. And Dr. Schneider is at Memorial Regional. And Dr. Sperry and myself were here at Henrico. And Dr. Sperry is actually just doing clinics. He does not work in the hospital these days, but so I've come and take his spot.